When we're talking about cardiac transplantation screening, there are three questions to start off with. Is it necessary? Is it possible? But also, do you want it? The purpose of heart transplantation in itself, of course, is to increase the lifespan of our patients, that they have survival benefit, but also when we do it, that they get increased quality of life. When we select patients for heart transplantation, it's of course patients with end-stage heart disease with a limited lifespan. Furthermore, there are no other sensible therapies available. And when we screen these patients, we also screen them for alternatives for transplantation, meaning a left ventricular assist device, which in itself can also be a bridge towards heart transplantation. And when we put our patients on the waiting list for heart transplantation, you don't want to put them on too early, but definitely not too late. When we see patients too early, we assess if they're already candidates for heart transplantation, and we assess the risks of putting them on the waiting list or postponing that. And when we see patients too late, we're looking at patients who are increased risk of mortality as well as morbidity, which might mean that they don't make it towards a transplantation, or it means that we do a high-risk heart transplantation where we can also lose the patient around the surgery. So there's definitely an optimal window where patients have a survival benefit and where the chances of complications are in line with the probable gains. And when we talk to patients, we also need to know if they are committed to going towards this difficult period with many uncertainties, because being put on a waiting list for heart transplantation means you have to wait for several years before a suitable donor organ becomes available. And then, is it possible? And for this to know, we need to screen patients to know if they're candidates for heart transplantation. For this, we have guidelines telling us what we need to do to get these risks all known, so we know how we can minimize the risks towards heart transplantation. One of these things we're looking at is contraindications, meaning if the heart doesn't work, all organs might suffer, meaning the lung, livers and kidneys need to have well enough function when you treat these patients with a heart transplantation that the other organs will still functioning well enough so that they get the expected benefits of their heart transplantation. Of course, it's also very much important that we know if these patients don't have any malignancy which causes their lifetime span to be decreased as well. And basically, patients need to be tumor-free for 5 years after they have a confirmed diagnosis of malignancy. Skin malignancies are very well treatable and usually are not a contraindication for heart transplantation unless it's a melanoma. And if you smoke, use drugs or use alcohol, you're not a candidate for heart transplantation. There's way more patients who are waiting for a donor organ than there are organs available. And active smoking decreases your lifespan post-heart transplantation by half. And that's not going to cut it for these patients. Furthermore, if you have any psychiatric disorders, it needs to be well treated for us to consider you a suitable transplant candidate. If we make agreements with you, you need to adhere to these agreements so we can treat you in the best way possible we see fit. Furthermore, you can see several contraindications on the right side of this slide as well. And these are all given in by the fact that when we treat you post-heart transplantation with immunosuppressive drugs, you're at increased risk of osteoporosis as well as renal insufficiency. And we need to know this beforehand to see if we can treat it very well for you to be a suitable candidate for heart transplantation. Otherwise, you might end up with fractures, which will also limit your quality of life. Furthermore, your BMI is also important, because if it's too high, the risks around this major surgery are too high for you to get into problems. And the BMI in itself, when it only increases furthermore, it's basically a gateway to several complications which we just want to avoid before transplantation. And finally, your age is also of importance. Is not a modifiable risk factor. Basically, if you're above the age of 65, your chances of getting through the surgery without any side effects are limited. So probably it's not a good thing to transplant you at that time. And you can better have surgery by getting an LVAD. And when we screen our patients, of course, we take all these factors into account. We do a thorough physical examination. We do extensive blood and urine tests. But we also look into imaging of the heart by echo and on an indication MRI and CT. And when we think we have optimized everything, we're going to do intracardiac pressure measurements by taking a Schwann-Ganz to see if we have the best results of the heart failure management at that time, but also to look at the risks towards transplantation. And then if your renal function is down, if your lung function is down, we're going to ask the pulmonologist and nephrologist to think with us, is there anything we can optimize before we talk in a multidisciplinary team to see if you're a candidate for heart transplantation or not. And then finally, it's also very important to look at other factors, meaning that we look at the physiotherapist, looking at the dietitian as well as the medical social worker, because you're not treating the disease, but you're treating the patient. So it's also important to take their vision into account. And after that, in our multidisciplinary meeting, we weigh the risks of putting someone on the waiting list for heart transplantation or not. And when we look at problems after heart transplantation, you have short-term, mid-term and long-term complication risks. When we look at the short-term, of course, it's surgical risks, as well as looking at pulmonary hypertension, which can cause RV failure of the just transplanted heart and which can also lead to cardiogenic shock. Furthermore, as soon as you put the donor heart in, there's chances of rejection of this donor heart. So we need to optimize our medication to put in immunosuppressive drugs, but we can't put it in all in one go. If that would be possible, that would be ideal, but that's not the case. So we slowly titrate this in. But as soon as you dampen the immune system, you're at an increased risk for infection as well. And chronic dampening of the immune system can also cause that you're increased risk for malignancies. Furthermore, these drugs can cause renal damage, but it can also cause diabetes. So cardiovascular risk management is important to optimize the outcome of these patients. And the thing we're still looking for is the holy grail within heart transplantation is to treat coronary artery disease of the heart transplanted patient. It's different than what we see in the general population, and it's also something we screen for each year because patients after heart transplantation don't experience any chest pain anymore. And in Rotterdam, we preferably perform CT scans to look at coronary artery disease, which is a way to assess over time how it evolves. And when we put all these things together and we talk in a multidisciplinary meeting about if a patient is a candidate for heart transplantation, there are basically two outcomes. Either you're at increased risk where we're saying you have absolute contraindications for transplantation and we're not going to do it, or there are relative contraindications, but we think we can manage them and you're listed for heart transplantation. And when we look at survival post-transplant, we can see that we look at our old cohort, it's the red line in this slide, from 1984 until 2000, you can see that the 10 years median survival was just below 60%, but in the new cohort, the blue line, you can see from 2000 until 2013 that although patients waited longer for heart transplantation and patients got, on average, older donors, you could see that the lifetime expectancy has increased. And if we would make a third line above this, from 2013 until now, it's probably somewhere around 74%. So we're still improving our care both pre and post-transplant. As such, screening for heart transplantation determines both short and long-term outcomes after transplantation, and teamwork is essential to get the best possible outcome for our patients. And this all is within the mission and vision of our Transplant Institute. I thank you very much for your attention.